Assalamu alaikum. 22nd of June 2026. I warmly welcome everyone to my colleagues. And today we topic discuss and try to simplify and try to understand manage trauma coagulopathy. This is the 2026 evidence-based framework built for anesthesiologists who must act in first 10 minutes. And this is not theory, this is level 1 randomized controlled trial evidence combined with military medicine experience. When adopted, these practices save life. ATC is not a passive consequence. ATC summary, I just summarize here. So what we are going to discuss is the acute traumatic coagulopathy, ATC. It's a distinct pathophysiology requiring early intervention as proven by the CRASH 2 and military medicine trials and evidence-based. I just want to emphasize on this one that ATC, acute traumatic coagulopathy, begin within minutes due to endothelial injury, protein C activation, and hyperfibrinolysis. Early intervention like thromboxane, fibrinogen, and whole blood and calcium and rotem based management reduce mortality. Why we choose this topic? Because as we know, in the Western world, even in Saudi Arabia, the highest rate of death is from in youngster age group is from trauma. And we have seen a couple of years back that trauma rate in Saudi Arabia is almost, death related to the trauma is almost 4,000 and around every year. 4,000 almost youngsters every year dying because of the trauma. And in trauma, the hemorrhage is the number one preventable cause. If we can treat preventable cause like ATC, then we can reduce the mortality. Just imagine, I want to make sure that ATC double mortality. That's why I highlighted this point, double. And if we early do correction, we can save the life. Here comes the anesthesiologist's role as a first line of defense. I divided my whole presentation into 8 pearls or 8 points. So we can understand the trauma coagulopathy in a better way and simplify the management and create a sort of protocol out of this one. So number 1 point is the ATC, acute traumatic coagulopathy. It's a disease just like other pathies like cardiomyopathy, like myopathy. It's not the blood loss. Second thing is the fibrinogen fail first. It's a loss of the fibrinogen which has to be treated as soon as possible. Third point is the whole blood is superior. We'll see in few slides that how the trend is changing from 111, like 1 ACPAC RBC, 1 FFP.
It's 4 o'clock. It's 16 hours.
And platelet. Fourth point is the calcium, most neglected and life-saving drug. Tranexamic acid, timing is everything in that tranexamic acid. It has to be within first 3 hours. Crystalloids are toxic. Number 7 point is the rotem or TAG, which it is a new standard. So it's a paradigm shift and sequential algorithm. First point or first pearl is ETC, not a blood loss. During shock, what happened? Endothelial glycocalyx shedding, protein C activation, proteins and activation inhibit factor 5 and 8, drives fibrinolysis, hyperfibrinolysis, clot breakdown, and it's a lethal phenotype. I just make it highlighted. Hyperfibrinolysis, it will cause clot breakdown. Timeline is everything. Begin within 5 to 15 minutes before dilution or before hypothermia. Clinical reality. If PT, APT, they lag for 30 to 45 minutes. Suppose we take a sample now, and by the time the result will arrive, the scenario may be already changed, or it may be 180-degree different, because it will tell you the same scenario once we take the sample, and by the time maybe it's not yet even the start of the coagulopathy or some. Rotem detect it immediately. Key point is, if we wait for the lab result or clinical bleeding, if we see the bleeding, then we start our intervention, then we are already late. Second point is fibrinogen fail first. Why and how to fix it? Why fibrinogen? Because fibrinogen is the backbone of clot strength. Normal fibrinogen level for a healthy adult typically range from 200 to 400 milligram or 200 to 400 milligram per deciliter or 2 to 4 gram per liter. This essential protein produced by the liver it plays a crucial role in your body ability to form blood clot and stop bleeding. Fibrinogen is the structural backbone of the clot. No fibrinogen is equal to weak clot and there is a bleeding. In massive trauma, fibrinogen immediately drop from 2 to 4 gram per liter to 1.5 gram and is nearly universal and occur early. FAP is dilute, slow, unreliable. So fibrinogen concentration is concentrated and fast, and this should be the first line of management for us. ATC origin is the endothelial. So what happened in normal state, endothelial lined by the glycocalyx. It's a gel-like layer. Its function is to protect as a protective barrier, keep the vessel anticoagulant. What happened in shock? Once shock hit, there is a hypoperfusion. Plus there is a sympathoadrenal shocks. That sympathoadrenal shock plus hypoperfusion combination lead to endothelial injured and activate. Once it is injured and activated, glycocalyx sheds and there is a two simultaneous effect happen. There is leaky vessels, fluid and protein escape from the tissue and it causes edema and IV fluid loss. Second thing is it causes procoagulant flip, tissue factor exposed, anticoagulant service trapped, and it accelerates the coagulopathy. I will try to rephrase it. Hemorrhagic shock, there is a shedding of glycocalyx, immediately coagulopathy due to leaky vessels and procoagulant flipping. So we have seen just endothelium takes first hit. Now when endothelium is injured and perfusion drops, then thrombin that is generated bind thrombomodulin on the vessel wall and switch on protein C. Once this protein C is activated, normally this is a helpful phenomenon during the normal physiological time. But in trauma, This same brake is slammed on far too hard and it becomes a major driver of early coagulopathy. Activated protein C does two damaging things at once. It inhibits factor 5 and 8, promote fibrinolysis, and drive early coagulopathy. Hyperfibrinolysis. Hyperfibrinolysis is a lethal phenotype. Plasmin conversion, overactivation, clot breakdown, and lysum. Rotem will show us increase LY30. LY mean lysum at 30 minutes. Thromboxane prevent this one. And elevate LY30 on rotem or rotational thromboelastometry assay in massive transfusion medicine indicate hyperfibrinolysis, a dangerous state where blood clot break down prematurely. Our rotem or TAG will show fibrinogen deficiency before anything else. That's our signal. If we don't have rotem or TAG, assume low fibrinogen in shock plus hemorrhage and give it anyway. Implementation is immediately dosing 2 to 4 gram fibrinogen concentrate IV. Timing is very important, early as part of the initial massive transfusion protocol. Why we should not choose the FFP? FFP is slow to and it make the weak clot. Cryoprecipitate is in between, it's a medium and it's a fair. Fibrinogen concentration fast and the best one. So in practice, massive trauma, fibrinogen concentration is the first product to think about, 2 to 4 gram IV, not FFP. That's why I highlighted this one, not FFP, confirm with the rotem, TAG or lab fibrinogen level. Why fibrinogen concentrate, not the FFP? Why fibrinogen concentrate, not FFP? Fibrinogen concentrate advantages are it's a rapid administration, predictable dose, no volume overload, superior correction versus FFP. FFP has its limitations. It's slow in thawing, large volume we need, dilute other factors. Key message is use fibrinogen concentrate early, it saves time and blood. Our framework is built on level 1 randomized controlled trials, military observation data, and mechanistic pathophysiology. This is why it works. It's evidence, defense, and clinical proven. It's evidence dense and clinically proven. The clinical randomization of antifibrinolytic in significant hemorrhage trial. CRASH stands for clinical randomization of an antifibrinolytic in significant hemorrhage trial, also known as CRASH-2. PROPER stands for pragmatic randomized optimal platelet and plasma ratio trial. And we all know these two trials, CRASH-2 and CRASH-3 and PROPER trial, they were the landmark. CRASH-2 started and published in 2010, then so many criticism happened, and I think in JAMA again it's re-emphasized in 2013, and CRASH-3 started trial, and the PROPER trial published in 2015, and it's a large study which is that this study helped us to establish the combination of 1-1-1 ratio of 1 packed RBC, 1 FFP, and 1 platelet. CRASH-2 trial collaboration, it published in 2010 Lancet, studied double-blind randomized trial control, 20,127 trauma patient in 21 country. Finding was thromboxane reduced mortality from 14.5 to 16%. Critical benefit was only if given in 3 hours. After 3 hours, sometimes it's more harmful, increased thrombosis and no mortality benefit. Implication is coagulopathy develop quickly within minutes of injury. So we can give this one before the coagulation profile disturb. Military medicine evidence level 2 observation is whole blood is superior to component therapy. Implication is early aggressive intervention save life. As we see in this trial, JAMA 2026, 40 studies, 50,000 patients, whole blood is superior to combination of 1-1-1 regime as evidenced by the military. Randomized trial of viscoelastic guided versus conventional coagulation test in bleeding trauma showed that and signaled toward reduced mortality and improved homeostatic targeting, but underpowered for hard endpoints. Number 3 is the damage control resuscitation in massive transfusion medicine, referred to life-saving blood-centric approach to severe hemorrhage shock. The core guideline required minimizing crystalloid fluid, implementing a fixed ratio of 1-1-1 plasma platelet red blood cell, utilizing tranexamic acid, and practicing permissive hypotension. I mean, these guidelines, like Cream-Brohi Foundation and damage control guidelines, they help us to understand the mechanism and the management. ROTEM was the classical lab. PTPTT or APTT classical labs, it's slow in onset, take 30 to 45 minutes, as we know, and it detect disturbance only in plasma, does not reflect the whole blood clotting. Misses early ATC, coagulopathy is already underway by the time result return. ROTEM and TEG viscoelastic will show the whole blood reflect that its outcome is from the whole blood instead of the plasma. And it's real time, results in minutes, 10 to 15 minutes we are able to understand the way pathology is going on at the bed, and we can do it at the bedside, detect fibrinogen failure early, fifth time flags it before clinical bleeding starting. If we see the timeline of this one, acute traumatic coagulopathy timeline, in first 30 minutes, 0 to 5 minute shock, endothelial injury, then 5 to 15 minute protein C activation, then 15 to 30 minute fibrinogen depletion, then in 30 minutes dilution, acidosis and hypothermia. Now I try to summarize it again. I re-emphasize rephrases all my whatever I said. This one, ATC is a distinct pathophysiology, not just dilution or hypothermia. The cascade glycocalyx, protein C, fibrinolysis, hypoperfusion begin within minutes of injury. By the time we see the clinical bleeding, ATC is already advanced. This is why ROTEM or TEG early detection is critical, so we catch the coagulopathy before it manifests as a bleeding. In a severely injured patient, before giving a single unit of blood, coagulopathy is already present and progressing. Our role is to interrupt this cascade early, not react too late. This is why permissive hypotension and early blood, not crystalloid, is the modern strategy. We can ask the question, okay, but we have always start with the fluid like waiting for the blood. That was based on hemorrhage stopping naturally. Trauma does not stop bleeding, surgery does. So in trauma there is, if we keep on giving crystalloid and waiting for blood or waiting for it to improve, there is no improvement until we start the surgery and stop the bleeding. Our job is to get blood flowing while bleeding is being fixed, not dilute the remaining coagulation. Come to the third point, whole blood is superior to the components. Military evidence of low tier blood, group O whole blood has become the cornerstone of modern massive transfusion protocol due to its unique physiology and logistical advantage. By providing red blood cell, plasma, and cold stored platelet in a single physiological balance unit, it is significantly improved the efficacy of homeostatic resuscitation. These are the references cited here. You can see in the trauma 2017 and military medicine 2020. Why whole blood is superior? Because it faster in homeostasis, clot quality is better, dilution is less as compared to, because we need more FFP and more transfusion is, reaction is less as compared to the component part. Mortality observational, although it's lower in as compared to the component part. Military trauma data proven survival benefit, faster correction of the coagulopathy, lower transfusion requirement, safe and logistically efficient. US military and UK defense medical services already started the whole blood as a standard in the combat care. There is one caveat in this one, only work if stocked and thought. If not available, use 1:1:1 ratio, which is already a well-established practices with early fibrinogen. So if we don't have the whole blood, go for the platelet FFP RBC along with the early fibrinogen. In civilian adaptation, whole blood in civilian trauma, increasing usage level of trauma center, emergency medical services, pre-hospital whole blood program, improve outcome in massive hemorrhage, better homeostasis with fewer products. Civilian practice is catching up with military success. Number 4 point pearl is the calcium, the most neglected life-saving drug. Hypocalcemia is not obvious. Sometimes we miss it because the sign and symptom because of the hypocalcemia like hypotension, poor perfusion, and bradycardia, we are attributing it to the hemorrhage, shock, or blood loss. And but the real culprit is calcium, and correcting it can be transformative. The citrate, the physiology is citrate blood's anticoagulant bind ionized calcium. Every unit transfuse blood, more citrate in the patient. Result is profound the most neglected life-saving drug. And fortunately, it is easily available and cheap medicine. Why we neglect this one and why it's being not considered? Because hypocalcemia is not obvious. It does not show up a bright red lab or obvious any clinical sign. What are the clinical signs because of hypocalcemia, hypotension, poor perfusion, and bradycardia? We are attributing it to the ongoing blood loss. Or if there is a need of more of vasopressor. But the real culprit is low calcium, and correcting it can transformative. Physiologically, the blood transfusion bind packed RBC, bind ionized calcium, citrate. It's in every as we all know that packed RBC have the citrate as an anticoagulant, and that citrate bind to the ionized calcium inside the body. Every unit, once we transfuse, more depletion of the citrate in the patient. The fifth point is the tranexamic acid, and the timing is everything in this one. CRASH 2 trial, look at the number of this patients, 20,127. Mortality benefit is 14.5 as compared to 16% if given before 3 hours. CRASH 3 also benefit in mild to moderate traumatic brain injury. Mechanism is fibrinolysis inhibitor, preserved clot in hyperfibrinolysis. So dosing is 1 gram bolus is IV over 10 minutes, then 1 gram over 8 hours. Key point is given as soon as possible within first 3 hours windows. Timing is very critical as proven in the CRASH 2 and CRASH 3 evidence. It's a level 1 evidence published in Lancet 2010 and 2019. CRASH 3 published in Lancet 2019. Crystalloids are toxic, 6 points. Normal saline is a hyperchloremic acidosis produce dilution worsen coagulopathy. Damage control resuscitation showing us stop fluid early. Permissive hypotension is acceptable. Systolic blood pressure between 80 to 90 in traumatic brain injury, and even 60 to 70 in non-traumatic brain injury. We can accept that one till we secure the homeostasis. But it's of course it's a time limited. We cannot continue 3 or 4 hours with permissive hypotension. And blood is our resuscitation fluid, not the crystalloid. If crystalloid needed, use balanced salt solution instead of the normal saline. Principle is reduce ongoing bleeding, prevent delusional coagulopathy. So it's a paradigm shift again also this point. Don't give the crystalloid, give blood in massive hemorrhagic traumatic injuries. ROTEM or TAG is a new standard now. Visual testing ROTEM or TAG superior to the APTT for massive transfusion hemorrhagic because it's a real time whole blood testings showing actual clot or strength. PTPTT too slow and unreliable and lag behind clinical coagulopathy. Fifth time detect fibrinogen deficiency early and guide and replacement. Result is 20 to 30% reduction in transfusion volume with ROTEM guidance. Interpretation is clotting time less than 40, give FFP. Fifth time less than 7, give fibrinogen. Lysum LY30 more than 3, give tranexamic acid. Fifth time your early warning system. Fifth time in massive clot firmness less than 7 millimeter, fibrinogen is showing the fibrinogen deficiency. First abnormality detected on ROTEM parameters. Guide early replacement, strong predictor of bleeding severity. Act on fifth time, don't wait for the labs. Eighth point is the massive transfusion algorithm in my presentation. So these are the points we first stop crystalloid, accept even the permissive hypotension. Tranexamic acid 1 gram IV immediately within 3 hours. Whole blood, if it is not available, then go for 1-1-1 component protocol. Fibrinogen concentrate 2 to 4 gram early, don't wait for the lab works. Calcium 1 gram every 4 units of the blood. ROTEM or TEG guidelines, ongoing laboratory, ongoing therapy, platelet, FFP or more fibrinogen. Maintain the temperature 36, mean arterial pressure around 65, and if there is a traumatic brain injury, maintain the mean arterial pressure around 80. What's a lethal triad? Lethal triads, coagulopathy worsens rapidly when combined with 2 other physiological derangement. Hypothermia, impair enzymatic coagulation pathway and prevent platelet aggregation. Acidosis. decrease the efficacy of clotting factor. Acidosis, hypothermia, and coagulopathy feed into one another in a positive feedback loop. So I used to say, and I'm emphasizing again 2 points. Coagulopathy happened and hypothermia. If we are not detecting the temperature, if we are not reading, if we are not monitoring the temperature and acidosis, moreover with the urine output, then the outcome of the patient is not good. It's not in our favor, not in the patient favor. This is Professor Karim Brohi Foundation research proven by the. So at the end, I just want to say massive transfusion algorithm, it's a sequential 8 points. Stop crystalloid, give tranexamic acid 1 gram IV over 10 minutes, whole blood if possible, otherwise go for the 1-1-1 protocol, 1 platelet, 1 RBC and FFP, give fibrinogen 2 to 4 gram, give calcium 1 gram every 4 units of packed RBC, and then follow up the ROTEM guidelines. Keep the patient above temperature of 36. This algorithm has 7 points. No? If we see this one, and the first 5 steps should be completed in first 10 minutes. What is the evidence hierarchy? Why this work? Because randomized trial, controlled trial giving mortality benefit like CRASH 2, CRASH 3 proper trial. Level 2 is the observational studies in high volume settings like in military medicine. It shows that the whole blood is superior. ROTEM guideline massive transfusion protocol, and it proven that the fewer transfusion reactions. Level 3 is expert opinion, pathophysiology and consensus guideline, like in as I said before, Karim Brohi Foundation guidelines, etc. Pathophysiology, damage control, resuscitations. We can make, what we can do is we can make these pocket cards and keep it in front in the every OR wherever we are doing our management for the critically ill patient or for massive traumatic patient. We can make like these 8 points and print it out like in small cards, and just so this is helpful because every time we cannot memorize, or maybe we are not following the whole steps, maybe we miss one steps in case of crisis. So it's better we can make a pocket card reference and keep it in our every OR. This is the front page, and the back page is the dosing and the ROTEM guidelines. Just like this one, dosing is fibrinogen 2 to 4 gram IV, calcium 1 gram over every 4 units, platelet 1 unit every 10 kg. Like if the someone is for 70 kg, we can give 7 units, tranexamic acid 1 gram, cryoprecipitate. If we don't give the fibrinogen, then we can use the 10 units. And FFP 10 to 15 ml per kg. ROTEM or TEG will tell us if the clotting time is more than 40 seconds, give FFP. If MCF, multi-clot, maximum clot firmness is less than 50 millimeter of mercury, give FibTab and platelet. If the FibTab shows 7 millimeter of mercury, less than 7 millimeter of mercury, give the fibrinogen. LY30 or lysum 30 is more than 3%, then give the tranexamic acid. We can implement in our hospital and make it like a checklist. So we should see our stock, whole blood available or no, and what's the calcium chloride 1 gram vials are available in OR. At the end, we can recheck it. If we start Massive transfusion protocol activation, it's in 3 steps. Because why I'm changing here is the
I will come to this one. I will answer myself. Okay. The dose is uh, 10, I mean 7 ml for 10 kg. So it is okay. Rotem check. Clotting time prolonged, give FFP. Fifth time low, give fibrinogen and cryoprecipitate. We can make a card, and because I think we cannot memorize everything this one, and it's not on a daily basis. So we can make a small card on this one and hang it with the tag machines. MCF is low, give platelet. And lysine 30, if it is more than 3, give tranexamic acids. Third step is recheck Rotem after 10 units of packed RBC. Once we give 10 units, now we recheck the whether on the Rotem. Fibrinogen usually need repeating dose. FFE may need another cycle. Platelet if maximum clot firmness is remain below. Okay, I know there are a lot of questions, so I ask myself questions and answers. Is it not 111 is a standard? Answer is proper trial 2015 established 111, but military data now shows whole blood is superior. Okay. Second question is, we don't have Rotem or tag. Like before we can say, or some centers still we don't have this facility. So what is the answer is execute protocol without it, but advocate for Rotem 20 to 30% transfusion reduction for this one. So if we don't have, start protocol, and we can request for the next in further future. I mean, permissive hypotension is safe. Answer is yes. A time limited, of course, it cannot be for 3 or 4 hours until surgical homeostasis. Monitor urine output and lactate during this time. I want to emphasize urine output because if we are asking our paramedics, give me the urine output, I mean, empty the urine bag, they will say, oh, 500 ml, we inserted just now. These are the answer I'm getting the feedback. This urine output may be from since morning, but this guy have trauma now. We have to see urine output, and this is the most sensitive indicator in the body. Urine output is the only monitor which is showing the tissue perfusion. And if that's what I said before, if we are not monitoring temperature, lactate, and urine output, outcome is bad. Okay, give fibrinogen without Rotem confirmation? Yes. In shock, hemorrhage, low fibrinogen is nearly always useful, universal, and give it, and it has confirmed by the Rotem study. Thank you. I know there may be a lot of questions. I will try to answer this one. So let's repeat this one. If the patient came now with, we are established already there is a massive trauma, massive hemorrhage. So activate the massive transfusion protocol, give fibrinogen in first 10 minutes, 2 gram to 2 to 4 gram, depend on the body weight. Take the sample, start preparing the Rotem, and start giving transfusion. We can give either if we don't have the whole blood, go for the 111 protocol. If we don't follow our hospital policy don't allow, then the other major centers they are doing, give 4 units of packed RBC, then 4 units of FFP and 1 unit of platelet. This is first. Then see the result of this one Rotem. If it is showing like a LY30, go for the tranexamic acid. Like if the fifth time is less than 7, fibrinogen. So these are the, I try to summarize, although it's a very extensive and very large I mean, thanks.
I have a comment.
Yes, boss.
Maybe the reason why the military are using whole blood because trauma for them is severe hemorrhagic shock. They have to start
That's true.
immediately with blood. But you start your lecture talking about
Co-
protein C and which lead to
Coagulop-
coagulopathy, and even though
I-
there is no bleeding.
There is no bleeding. Coagulopathy is starting.
This
Look,
is why maybe we have to use the formula 111 because there is no bleeding, but there is coagulopathy. But in military, there is severe bleeding.
like, okay, I will give you the example of PPH. And Alhamdulillah, by following this one, I remember this one, Misbah and Dr. There was 3 or 4 doctors. We saved already one patient with this protocol. On the each day,
One whole blood.
no, this fibrinolene. And believe me, we started at, but why we are not, there was a low, honestly, we, last, in the last 1 year, I was using only, before I didn't use at all, to be honest.
We didn't have it. We didn't have it.
And I will repeat again. There is 5 fibrinogen bottles in the fridge. In the main, the one near to our pharmacy, narcotic room.
Yes,
Please. One bottle is 2 milligram? Yeah, 1 milligram.
1 gram.
1 gram.
So,
Please. Anybody who uses the bottles, inform me so I can replace it. Don't use it and why?
I just want to,
Don't have a stock.
for those who don't use it, I just want to mention this one. It should be prepared in, if it is possible, warm, not saline, normal water, warm water, 35 degrees centigrade, and it should be shake slowly. I mean, there should be no bubble in this one, bubble to start this.
Regarding whole blood, we don't have whole blood.
Yes, that's true.
And the whole blood is still used for military as a logistic. We don't have the product. No storage and no blood bank. That's why they prepare whole fresh blood.
But
Whole fresh blood.
whole fresh blood is okay.
But here we are a tertiary hospital. We don't have a whole blood.
That's what I want to.
As Tarif said, it's against both protein guided and whole blood. This doesn't match.
But still, whole blood, even if it is stored, it is better than the FFB. This